Hi, everybody. Welcome to Congenital Heart Academy. We are very happy to have all of you with us today. I know that in most of the countries it's a hot summer, but we are really happy to have all of you with us today. So please follow us on social media and subscribe to our YouTube channel. We have some great news about the YouTube channel. We are going to have a new series that's going to be broadcasted only there. So please subscribe that you're not going to miss anything. And Congenital Heart Academy is very happy to co-host this training course. So if you're a surgeon, you want to have better skills for congenital heart surgery, you can apply for one or more of these topics. So this is something very nice that Sick Kids is making in a partnership with Congenital Heart Academy. So we have this 3D printed models that you can have very nice proctors to help you to go through the surgery for these specific diseases. This is going to be done and this year and next year. In the end of the year, we are going to have the big one, the big meeting of hosts. But you can every month have one training with one specific lesion. So please send them an email or go to this website and take a look at what they have. This is very nice, and we are very proud that Sasha is one of the proctors. By the end of the month, we are going to have our 7th webinar on fetal cardiology. We are very happy Norman is helping us with that. Dr. Rima is the coordinator, and we're going to talk about all of these interesting topics. And I'm very happy to have Julene, who is very well known for the fetal cardiology world, and she is Brazilian. And this is something that we're starting now only on YouTube. This is going to be awesome. So Sick Kids made a series about the history of pediatric cardiology. So they placed it together 10 sessions talking about the history of a lot of procedures. So they talked about how the percutaneous procedures were developed, how the arterial switch was developed, how the fontan was developed. So it was a very nice series, and you're going to be very happy to place these meetings on YouTube. So starting on August, every Saturday, we are going to have a new video on YouTube. You can watch at the time of your convenience. We're not going to have live sessions with questions, so it's going to be there for you to take a look. This is going to be awesome because we are going to be able to know more about our specialty. And now we are going to have Norman talking to us about single ventricle physiology, correlating morphology, and echo. He has done amazing sessions every month for us. And more than that, he joined a lot of other meetings of Congenital Heart Academy and contributed a lot with us. So Norman, thank you very much. I'm sure that everybody is very happy to have you with us, and everybody have learned a lot with your expertise and your very good sense of humor. We are very happy to have you, and we are really, really thankful. Thank you very much from our hearts for what you have been doing for Congenital Heart Academy and for our community around the world. And for sure, in September, we are going to continue with these amazing sessions. So now with you, Norman.
Thank you very much, Grace. I'm going to just prepare myself to do this this talk. I have to share my screen with you.
Yes,
firstly.
please.
And we're going to talk today about continue this series on the functionally single ventricle, which is so much a part of pediatric cardiology.
Norman, just one thing. Can you go to presentation mode? It's not on presentation mode so far.
Okay. Yes, thank you. How about that? Everything good?
Yeah, that's perfect.
Great. So this chapter I've made is part of a series that I'm writing in this book, which is available on this website, www.md1world.com. And of course, the lectures will be available. They're somewhat attenuated and don't have text on them to explain the things, because I'm doing the talking over here on our Congenital Heart Academy website. And I look forward to reading and seeing how many people have looked at these sessions. On an average, there are now 600 to 700 people that have hit back on the session to see how they work. So it's great that we have about 10 times as many people looking at this as are here today. So we're going to look at the functionally single ventricle, in this case, hyperplastic left ventricles. And the definition of this is an international definition, which the functionally single ventricle describes a spectrum of congenital abnormalities in which the ventricular mass may not readily lend itself to a partitioning that commits one ventricular pump to the systemic circulation and another to the pulmonary circulation. I think that's a very important definition to keep in mind. Now, we're going to talk really about hyperplastic left heart syndrome and other features. And this is Professor Anderson's definition. The phenotypic features of this syndrome are the presence of concordant atrioventricular and ventricular arterial connections, along with an intact ventricular septum. So there are many hyperplastic left hearts that are not hyperplastic left heart syndrome, and I'll show you some of them today. So we will discuss the absent left AV connection with mitral and aortic atresia. This is from Dr. Lev's classification, MA, AA, mitral atresia, aortic atresia. Then mitral stenosis with the diminutive left ventricle. And there are two kinds over here. There's ones where there's never been any mitral valve, and the other one where there is an atretic mitral valve that follows. Then there's mitral stenosis with aortic stenosis, and then we'll talk about the pulmonary venous obstructions from the intact or restrictive atrial septum, which we used to call the Levoatrial cardinal vein, but we have a different name for it now. So I'll keep you in suspense until I give it to you. And then we'll look at the alternative sources of pulmonary venous drainage. And finally, coarctation, and then look at the post-operative assessments, which are so important in this condition. So I've begun this first by looking at the spectrum of hyperplastic left ventricles. Under the left, we see something with a little sliver or slit and sometimes no left ventricle, but clearly an atresia between the left atrium and the left ventricle, an absent connection. Then here, the next one is a small left ventricle. I'll take the labels away for you so that you can see the tendinous cords within this ventricle, indicating that there's a mitral valve. We'll talk about this a lot later, but you can see that the endocardial fibroelastosis has heaped up under the left ventricle and made the cavity of the ventricle discontinuous with the aortic root. This is a more common variety of what we see. This is a quite unusual example. This is, unfortunately, you can't feel this in your own hands. This is from the UCSF archive, but this is actually calcium deposition here. And what happened to this ventricle is that during the course, it developed subendocardial ischemia. The ischemia lowered the pH, the calcium came out of solution, and when the ventricle died, it then all left itself as a bone-like structure around this left ventricle. There was an atretic aortic valve as well as a significant coarctation. Now, we'll talk about this a little bit in detail a little later, but here is an example of endocardial fibroelastosis. This is from my colleague, very good friend, Wayne Turetsky, who gave me this picture showing the endocardial fibrosis, which is marbled in white, like the Carrara marble of our Italian colleagues over here, that Michelangelo used to carve his famous statues. And finally, a heart where the left ventricle dilated, became infarcted, with patchy infarctions and fibrous replacement, and a solid bag of a ventricle that does nothing. So this is the spectrum of what happens on the ventricles. And similarly, the same thing happens in terms of the aorta. Here is the classical hypoplastic left heart, where the aorta is perfused retrograde, the coronary arteries are perfused retrograde from the arterial duct through the isthmus. And as the vessels of the head and neck are removed, there's only a flow to the coronaries necessary to perfuse this heart. Now, it's clear that hypoplastic left heart syndrome is a pleomorphic condition. There's not just one cause of this condition. It's not always aortic stenosis or burnt out aortic stenosis that leads to the development, although this is fairly common. And there are patients who I'll show you where the left atrioventricular valve has failed to develop, that the whole canal is shifted to the right and the right side has developed. And similarly, the same thing happens here with the aorta, is that the insult here is earlier than the insult was in this patient or this patient. And so we can see here no aortic valve, here possibly some aortic valve flow, and here relatively good aortic valve flow, even though the left ventricle is extremely hyperplastic. So we have to remember that this is a pleomorphic condition with multiple expressions of abnormalities that we can see. So let's begin with looking at our echocardiograms. And the echocardiograms will all have the same format. Here is the morphological specimen, and here is the parasternal long axis cut superimposed over here to show you what is happening here. The first thing that will happen, and I won't talk about this, but here is the position on the chest of the application of the heart of the parasternal long axis plane. So the plane will disappear, and then you will see the labels, which shows right ventricle, right atrial appendage, aorta, brachiocephalic artery. Here is the superior caval vein, which is not to be confused with the ascending aorta. Here is the pulmonary trunk, and here is the right ventricle leading into the aorta. And so we've matched this picture with what we see on the echocardiogram here, which will be slow. And you'll see the right coronary, the right ventricle, right atrium, left atrium. The sinuses of Valsalva are bulged. There's the coronary artery. Here's the ascending aorta. And here's the transverse aorta. And the color flow shows red flow coming back around the aortic arch and perfusing the aorta in the retrograde fashion. And we'll show you many of those pictures. Then the labels will disappear. And that will give you a chance to look at this. And then we will zoom in on these so that those of you who are happy to look at this on a cell phone can see a magnified view of what is available here. Here's another example in the parasternal long axis view. And this one shows the marked endocardial fibroelastosis with this marbling of the endocardium, the mitral left atrium, aortic root with the aortic valve, and a beautifully normal tricuspid valve. Look how abnormal the aortic valve is compared to the tricuspid valve. And when we look at the echocardiogram, you can see that functionally this ventricle is very, very poorly contracting, that the valve is doming, and then with Doppler color flow, that there is actually forward flow into the aorta, although this isn't enough to sustain the circulation. So this is an evolving hypoplastic left heart syndrome with aortic stenosis and mitral stenosis. You can see how small the mitral valve is and how little excursion there is on this mitral valve. Here's another example in parasternal long axis. I start my examinations in this way, and you can see here the thickness of the cavity and the smallness of the wall and the smallness of the cavity. You can see that the ascending aorta is much smaller than these vessels, the head and neck, which have been given, and that the right pulmonary artery is hypertrophied because of the restriction at atrial septal level, which we'll discuss a little later. And here is the echocardiographic equivalent, showing mitral stenosis, little insufficiency, and you can see a doming patent aortic valve. And note how large the right ventricle is doing the work of two, as well as the fact that there is hypertrophy of the right ventricular wall. Now, if we turn the heart round and look at it in short axis, and here's the short axis cut, looking across this ventricle as we see it here, you could see the marked endocardial fibroelastosis, the hypertrophy of the papillary muscles and the left ventricular wall, but with a cavity that is markedly reduced in size when compared to this hypertrophic right ventricle as well. And what we have on the right-hand side here is an echocardiogram of a patient like this. And you see that there's endocardial fibrosis. Here are the two papillary muscles within the left ventricle. Here's the tricuspid valve, and the right ventricle is seen anteriorly. And what I've done is I've matched this up with a fetal example at 21.5 weeks, and I've made the scale equivalent. So you can see, in fact, I haven't really increased it because I didn't have room to do this. But this left ventricle has not grown at all. Now, this isn't the same patient, but this is the feature that we followed in terms of the development of hyperplastic left heart, is that when the endocardial fibrosis starts over here, it restricts ventricular filling. And of course, the ventricle can't contract because this is a thick, fibrous, non-compliant ventricle. So the ventricle gets fixed in size depending upon the time where this insult occurred. And here you can see the comparison between a 21-week and neonatal fetal echocardiograms at approximately the same degree of magnification. Here's 1 centimeter and here's 1 centimeter. Here is a beautiful example in short axis of some of the things that you can see. The first thing that is important is that this is a pseudo-unicuspid valve. And this valve was ballooned several times in utero, but every time it was ballooned, the valve simply opened, and then when the catheter was removed, the valve removed to its closed position with this pseudo-unicuspid appearance here. And you can see this and the coronary arteries coming off this here. And here is an echocardiogram showing the aorta and the left coronary, giving rise to the circumflex coronary artery over here. And we'll see why in a minute, because the scan is moved from cranial, where the aortic root is seen, to caudal, where the left ventricle is seen. And you can see a number of these, what used to be called sinusoids, which we now call, excuse me, myocardial fistulae. So I'll let you look at that in real time and magnify this up. And you can see that one of the problems we have echocardiographically in terms of the short axis is that this is right and left, but from above, this is right and left. So they are mirror images of each other, because echocardiograms are always looked at the ventricle from below upwards. Now, here is this patient I showed you, which has mitral atresia and aortic atresia. The reason why is that there is an absent connection between the left atrium and the underlying ventricular myocardium. There is no left ventricle essentially in this heart at all. It's just a right ventricle. Okay, here is the oval fossa here, and here is the echocardiogram, and you see the tricuspid valve and right ventricle. Here's the left AV groove between the left atrium and the underlying mass, but there's no left ventricular mass underneath this myocardium. Now we can do this in the subcostal view, and this is a sagittal view. I'll start off with this first, because I have this beautiful specimen which has been cut in a subcostal view to correspond with the echocardiogram. So you can see this diminutive left ventricle, the big right ventricle, you can see this tiny aorta, the pulmonary trunk, the origin of the pulmonary arteries, right atrial appendage and duct. Here's the left pulmonary artery. The pulmonary vein is seen over here, and the left atrial appendage here. Now, when we look at the echocardiogram, you can notice when you see papillary muscles that there's usually a small mitral valve present in here. And here are the same features. Here's the liver. And you can see how small this newborn aorta is compared, left ventricle is compared to the right ventricle. And so we'll just rotate those round. So now the orientation is exactly the same. Here's the diaphragmatic surface of the right ventricle. Here's the papillary muscles and the caudal apparatus of the tricuspid valve, the infundibulum and the pulmonary artery above. And here is the small hypoplastic, poorly contracting left ventricle. Here's another example with another small left ventricle. And what I've been doing in this series is we're going to look at larger and larger left ventricles in association with the hypoplastic left heart syndrome. So here's the aorta. The aorta has a valve in it. There seems to have been some connection. The valve is not patent. And here is the echocardiogram showing you the same features again. And then we zoom in on this so that you can get a good look on your cell phones if you're looking at it like that. And of course, here's this left ventricle with endocardial fibroelastosis, not so well seen in this particular example, but there is some thickening of the endocardium. And here is a well-contracting right ventricle and a non-contracting left ventricle. Here's the first specimen that I showed you, but in this case, we've matched it with an echocardiogram that shows one of the persistent and most significant problems, the development of tricuspid regurgitation. And here you see, as we take the plane off from the apical four-chamber view, you can see the absence of the connection between the left atrium and this slit-like virtual left ventricle. The foramen ovale is shown here, oval fossa is shown right over here. Here's the inferior caval vein. So big right ventricle and an absent connection. And now when we look at the echocardiogram, you can see that there is tricuspid regurgitation and that the right ventricle is dilated here. The right ventricle is handling the entire circulation. And of course, as it increases in size, it stresses the tendinous cords, the whole support structure for the tricuspid valve, and tricuspid regurgitation develops. And of course, the valve then takes a hit and becomes abnormal as well. So there is, I think, poorer function of this right ventricle than we usually see, but it's associated with tricuspid regurgitation even before a Norwood procedure is done on this patient. You see the papillary muscles and the extensive tendinous cords attached to the underlying ventricular myocardium with poor ventricular contraction. Now, the next series up on this is to show a small left ventricle with these tendinous cords here and the small mitral valve. I'm going to take the echo cut picture off so that you can see the labels, and I've highlighted the valve from Dr. Spicer's collection to show a small atretic mitral valve, and you will notice that there's no endocardial fibroelastosis, so that this ventricle never developed any left ventricular pressure, and so the endocardium is pristine. Here's the atrial septum, here's the oval fossa, here's the back of the trabeculations surrounding the vestibule of the tricuspid valve with the right ventricle here. So teeny weeny left ventricle. And here is the same small left ventricle here on the echocardiogram, again without endocardial fibroelastosis. There's a widely patent foramen ovale in this case, but you can see the septum primum bulging across from the left atrium into the right atrium. Here's the descending aorta as a marker. And you can compare the size of this ventricle with this diminutive mitral valve compared to the tricuspid valve, and the size of this well-contracting right ventricle. Excuse me. So now we look at another heart, and in this heart here, taken in a 4-chamber cut, you can see the presence of a mitral valve which was patent, developing pressure in this left ventricle and leading to perfusion abnormalities within the subendocardial layer and giving rise to endocardial fibroelastosis. Also, when ventricle blood gets in here, there's only 2 ways it can get out. It can get out through mitral insufficiency, or some of it can exit through these ventricular coronary connections, which used to be called sinusoids. And this heart very clearly shows the definition of sinusoids lying within the mass of the hypertrophied ventricle. And note that the right ventricular apex forms the apex of the heart in this condition. And we've matched these with 2 echocardiograms. This one is from a fetus, an early gestational fetus, and in mid-trimester. You can already see the endocardial fibroelastosis here. You can see the atrial septum restriction. And here is a postnatal example of the same, and the comparison for sizes are the same. So we make this point once again, that once you get endocardial fibroelastosis, as you see here with the small papillary muscles, that the ventricle size is restricted from growth. So that's the important issue, is that once you get that, the ventricle's fate is actually sealed. Now, we can do operations after birth to remove that fibrous tissue, but it never makes a big ventricle if it's small like this. So here is a larger left ventricle to look at the themes. Also, with a patient with hypoplastic left heart, with a mitral valve and either aortic stenosis, aortic atresia, not shown on the specimen. And here again, you can see the ventricle with this diminutive mitral valve compared to the tricuspid valve and the right ventricles. And you can see flow coming in the left ventricle and then entering out through the tricuspid valve into the right ventricle. A lot of pulmonary blood flow here because, of course, the blood is going around into the pulmonary arteries largely, with a large left to right shunt. Now here's another example of a larger left ventricle. You will notice that there is a thin sliver of endocardial fibrosis that's developed here. It's not well developed, and the ventricle is of moderate size. And here is an example from a near-term fetus showing that this ventricle is small, but is certainly well developed with all of its characteristics, and seems to be functioning reasonably well. Notice also the foramen ovale is very small in this patient, and the atrial septum is somewhat thickened. Now, here's a much larger left ventricle. In fact, this baby had a patent aortic valve, had mitral stenosis. You can see how small the mitral valve is. You can see the diminutive papillary muscles, and most importantly, this marbling of the endocardium, which exists all the way around. And so that there are layers of perfusion that occurs, which we'll discuss in a moment. But this myocardium is reasonably well perfused, and this myocardium already has had substantial ischemia with endocardial fibroelastosis. And you can see that here. You can see the diminutive mitral valve. And what I haven't pointed out is that this patient underwent a stent procedure for the mitral, for the deficiency. Look at the small papillary muscles, the small mitral valve. There's the descending aorta. And here you can see this stent across the atrial septum. the left ventricle's function is poor compared to the right ventricle, as is usually the point in these patients. And of course, this patient did very poorly and yielded the heart to the UCSF archive. Now, here's a picture from Professor Anderson, and I wanted to show you this 21.5-week fetus here with a small left ventricle, a bigger right ventricle, and at this time in utero, fairly reasonably spaced valves. At birth, the pulmonary artery was large and the aorta was small. What I want to point out to you is that if you look at this endocardium, you'll see different gradations of color. And the different gradations of color relate to the perfusion. And so we know that the myocardium is perfused by coronary arteries that run from the outside inwards, and that work of the myocardium is from the inside outside. The inside layer has to contract more than the outside layer, otherwise there would be incoordinate contraction and the ventricle wouldn't work. And so there is a gradation that develops, like the story is that we pediatric cardiologists know of Goldilocks and the three bears. So there are three layers. There's a layer on the outside which has excessive perfusion to the amount of work, a layer on the middle where there is the same amount of work as there is perfusion, and then the layer on the inside where the work exceeds the perfusion, and that leads to this development of endocardial fibroelastosis that you can already see in the fetal example here, and to a very much lesser extent in the neonatal example. But what you can see here is that this aortic root was not receiving a lot of blood. The blood flow started to become retrograde. There are the coronary arteries. Here's the sinuses of Valsalva, and here's the ascending aorta. So the process of development leads to the continuing development of hyperplasia of the left side of the heart. Here's another one showing extensive endocardial fibroelastosis, mitral atresia, aortic atresia, and mitral stenosis. Here's the left atrium. Here's the endocardial fibroelastosis. You see there's hypertrophy of this left ventricle. Here's again some myocardial sinusoids or fistulas, and here is the right ventricle. And here is the neonatal example. And you can see the EFE very clearly here, scattered all the way around the heart. And you can see it on the echocardiogram as well from the apex here. I've matched these up to show you that from 26 weeks to a neonatal period, there's been little growth in this left ventricle. Now, this is the same picture as we've seen before, but we're looking at the presence of aortic stenosis and mitral stenosis. Of course, there's the ever-present endocardial fibroelastosis, much more marked on this particular example, but still present on the endocardial surface of the ventricle. And the one way of looking for this, of course, is as axial resolution in this direction is better than lateral resolution, that you should always look for the endocardial reflections on the surface of the ventricle, which is axial to the transducer position. So look here, here's this big, thick hypertrophied right ventricle, which is dilated. There's probably a little tricuspid insufficiency that I'm not showing you on this picture. And again, the comparison between a bicuspid abnormal valve with thickened rolled edges compared to the normal pulmonary valve that we can see here in the short axis. Now let's look at the aorta. Here's our old friend, the hyperplast, with the pulmonary trunk leading to the ductus and then down the descending aorta, as well as up through the isthmus, showing the head and neck artery perfusion. And then the only thing that needs to perfuse the coronaries is the ascending aortic conduit. And this is a very easily recognized issue here, a common feature. You can see the small left ventricle on this side, and this is all right ventricle. And here is the echocardiogram, and the echocardiogram shows the presence of the ductus here. There is a coarctation here with acceleration of flow. There is, you see the vessels, head and neck, and then the ascending aorta comes down towards the heart here. And I think it's better seen on the Doppler color flow. And what's more important and very significant in terms of looking at a failed left ventricle is that when there is retrograde flow around the arch, and here is the retrograde flow, as you see on the Doppler, and then there is retrograde flow down the descending aorta, just blue flow in systole, perfusing the coronary vessels and the myocardium of the entire heart. Here's another look at a small ascending aorta. Compare the size of the pulmonary trunk to the size of the ascending aorta. Here's the head and neck arteries. There's the arterial duct. And here, looking at the heart once again, you can see this minuscule ascending aorta with biphasic flow in it because it's not easily identified. There's some coronary sinusoids present, or coronary ventricular fistulae, as Professor Anderson would like to call them. Now here is a bigger ascending aorta, as you can see here on this example. There's still endocardial fibroelastosis because there's mitral insufficiency. Here's the flap valve of the fossa ovalis, which is open. And here is the pulmonary trunk on this side. So we're looking from the left side, open this. There's a coronary vessel within the ascending aorta. And here you see the sinus of Valsalva is usually larger. And then here is a moderate size ascending aorta. This is no more than 4 millimeters in size in the ascending aorta. So there's notice that in this patient, there's already heart failure with the presence of a pericardial fusion surrounding the heart in this condition. Now we're going to look at the significance of a coarc. And coarctation occurs in two series of between 70 and 80% of patients. And the surgeons know this because they have to excise this and put in a patch, because the failure of recognizing coarctation and dealing with it, it's the hardest part to operate on, will lead to the recurrent coarctations, and that is in a single ventricle circulation leads to heart failure and death. So it's very important that we recognize this. We can see it in utero. I'll show you this wonderful specimen courtesy of Andrew Cook in London, where you see that the coarctation is pre-ductal. So the bad news is that if there's a coarctation, in order to perfuse the head and neck and the coronaries, there is already obstruction. And of course, the obstruction can go into the vessels to the brain. And of course, one of the things is that we all study now the fact of neurological development in these patients. And we attributed this before to perfusion abnormalities, but there are multifactorial issues that are involved in the neurodevelopmental loss that occurs in hyperplastic left heart syndrome. And once again, the coarctation that you can see here with acceleration of flow, with retrograde flow, red flow is retrograde in the arch and then down the aorta. We've seen that before. I'll just move on in the presence of time. And now we'll look at another patient who's got prograde flow across this abnormal aortic valve. Notice this beautiful false tendon within the left ventricle. Dr. Van Praag said that this contains Purkinje fibers. So here's an example of Purkinje fibers, endocardial fibroelastosis, mitral stenosis, and aortic stenosis. There's the oval fossa, and here are the echoes that match that, taken in parasternal long axis. Okay, and you see here the valve opening and closing. You can clearly see it opening. And then when you add color flow to that, you can see that there's a jet of red flow coming up here, but it stops there and there's now retrograde flow around the aortic arch. So this is a patient with mitral stenosis and aortic stenosis, as I've indicated in the heading of this particular presentation. So you see in this patient that there's forward flow, but it doesn't go much further than the ascending aorta, perhaps a tiny bit of flow coming out into the brachiocephalic vessel, but all of the flow is coming retrograde. And there's also, looks like with the acceleration here, that there may be a coarctation as well. Here's the right pulmonary artery just for our sight, and this is the left atrium with the flow in the left atrium. Here I've put the same specimen, but I've matched this with a different echocardiogram. And you can see here that the whole aortic isthmus is hyperplastic all the way round to the ascending aorta, which in this case originally had some prograde flow to it. So this is a very important variability. And here's the arterial duct. So this is all pre-ductal coarctation, but the whole arch is hyperplastic relative to the demands that are needed to perfuse the upper body. And here's the number I left for you to remember. 70% of hyperplastic also have coarctation. I saw this session when I was working with Bob Anderson and Diane Spicer in Pittsburgh in the 1980s. And the study was done by Dr. Tony Moulton and also by Dr. Cora Lennox. 2 studies showing the same. So I spend a lot of time on coarctation because it's very important. And also this is the area that is deepest in the chest and the hardest for the surgeon to actually get to. Of course, he has to take all of the ductal tissue away because the ductus will then constrict afterwards. And so we look at this early on to look at what we can see here. And here again, you see this very small hypoplastic aortic arch with already some prograde flow into the aorta, but not going very far anyway. But initially there was more, and that's why the aorta is better developed, the ascending aorta, but the arch is poor. Now we'll move on and look at the oval fossa. This is a beautiful picture from a textbook that I co-authored. The picture comes from Andrew Cook, and it shows the thickened left atrium with a restrictive oval fossa here in utero. And that is a big problem in terms of making a good prognosis for these patients. And you can see how thickened is the atrial septum. I'll take the labels away. You can see the lungs have got a reticulated pattern on them, that the pulmonary arteries are very hypertrophied. And here is a little minor mitral valve abnormality, a dilated coronary sinus, a big hypertrophied ventricle, and clearly this is right atrium with the pectinate muscles surrounding the vestibule of the valve. And here is an echocardiogram that shows the presence of restriction of flow across the atrium. Now here is, you can see a very small opening between the primary septum and the flap valve over here. And this is no more than about 2.5 to 3 millimeters. And this, of course, is a postnatal example. And so if this patient wasn't in real trouble, we would have just excised this in the Norwood procedure. But here you can see in the fetus, you can see the oval fossa, and there's lots of labels over here. But I want to point out the oval fossa, the left atrium, the atrial septum, the left ventricle, which is a minuscule structure, and the right side of the heart. And I will take away those pictures just to show that to you. And here you can see this red flow is flow coming across the foramen, and that is the flow of the pulmonary vein going into the left atrium. So here you see this doesn't look that restrictive over here. And then when we zoom in on that, you can see again that jet coming across the oval fossa, not a very good prognostic sign. And if, of course, this occurs early on and we cannot do anything about it. And most of these, this is not really a highly successful procedure to stent the atrial septum in utero, to perforate it and penetrate it. You get this kind of pattern, which is pulmonary lymphangiectasia with obstruction. And you see here the terrible vascular markings and damage in the lungs that you see here. And here is a restriction of the atrial septum, and the Doppler shows you this characteristic high velocity, 13.4 millimeters of mercury pressure difference between the left atrium and the right atrium in terms of transatrial flow. And here you see the right pulmonary vein draining into the left atrium. Now I've got more pictures to show you in this. Here's another example where there's no evidence of an atrial communication. The septum primum is thickened and has prolapsed through the oval fossa, which you can see over here, into the right atrium, which is hypertrophied as well, and the coronary sinus is dilated. This also comes from Andrew Cook, and here is the reticulated pattern of the crop of the pulmonary artery, the lungs, I beg your pardon. And on microscopy, you can see these huge lymphangiectatic areas that are consequence. And here is an echocardiogram showing a restrictive atrial septum. Once again, you can see the septum bulging through the oval fossa, as you see it here. To a little dot over here, probably related to issues such as that there. The left ventricle, again, is hyperplastic, but we're not concentrating on that. And look at the dilatation that occurs in the pulmonary veins with the thickening on the pulmonary veins, which can lead to lots of post-operative issues there with these patients. And here is a patient in whom an attempted stent has been placed. You can see the stent is held in this thickened atrial septum. So that not only does the septum remain like we normally does, septum primum is thin, but it can hypertrophy, and then it becomes impossible and has to be perforated, as you'll see over here. But you can see the stent lying across this atrial septum. And I've matched that with 3 examples showing the stented atrial septum. You've seen this one before. Then we look at the next one, which moves there. And here you see the stent in the subcostal coronal cut coming across the atrial septum. And lastly, you can see the stent in the right atrial surface with the flow coming in and a little tricuspid regurgitation. And now we'll just allow the interventionist to blow up the balloon. He's just setting the right atrial surface now before he fully expands the stent. And then here is the comparison between the morphological and the echocardiographic appearance. Left atrial component of the stent, the interatrial septal area, and the right atrial aspect, and good flow coming from right to left, with a moderate sized left ventricle, but notice how poorly it's contracting. And then here, once again, I show you this specimen, which we've seen before, and we measured this. This is nearly 4 millimeters. And although there's a jet coming across here, it may not be that restrictive, because remember, the pulmonary blood flow becomes very high in this condition. Now, the other thing that has been observed is this leftward shift of the septum primum. It's described by the late Paul Weinberg, who we remember very fondly. And here you can see the right upper pulmonary vein has got this wire placed through it. The wire comes into the right atrium and then goes other side of septum primum. Here's the primary fossa here, over here. And you can see that this vein is actually entering the right atrium. And here is such an example of the leftward shift of the atrial septum. You can see the left to right shunt. You see the pulmonary vein here just distal to the pulmonary artery, with the flow coming in to the right atrial aspect, just proximal to this bulging atrial septum. There you go. Now I want to move on to other problems, and that's this problem of the myocardial sinusoids or ventricular coronary fistulae. And here's a beautiful example from Dr. Diane Spicer's collection showing the left and right coronaries. Here is a left ventricle with a little mitral valve on it, an endocardial fibroelastosis. And here is an example from my colleague David Roberson, who has a paper out on this topic and shows these presence of these things which we are much more likely to identify in hyperplastic right heart syndrome. But anytime ventricle is obstructed and these primitive Thebesian connections are present, or sinusoids or fistulae, there's a way of escaping from the left ventricle. And so you see, this is the anterior interventricular artery. Here's the right coronary artery running around there. And here's another example that I've matched showing left and right coronary arteries. Here's an angiogram in hyperplastic left heart syndrome with sinusoids. And I want to point out the extensive coronary artery connections with the ventricle. And if you look in this region here where I'm putting the arrow, you will see that there is, I'm going to take the labels off so that you can see that. Just next to the catheter, you can see the little fistulous connection retrograde from this vessel. And I've matched that with this previously observed example, which shows the coronary vessels running out of this left ventricle and into the coronary vessels. And of course, if this is the circumflex coronary, the flow is going retrograde. Okay. All right, so I think here's the last example, and here is this little area here, and you can see the endocardial fibroelastosis. So we've seen fistula there, but this is a large fistula from Diane Spicer's archive showing this minuscule left ventricle here with the right ventricle here, and this is the circumflex vessel running back here. And here is a 4-chamber view from Dr. Roberson from his paper. And you can see this right coronary artery running back. Here's the little left ventricle and into the aorta and retrograde into the aorta. You can see the sternum and the spine indicating the position of this heart within the left hemithorax of this fetus. Now we'll move on once again, and we're moving now to talk about the so-called levoatrial cardinal vein. Now, the levoatrial cardinal vein has been a well reported problem. This is from the oldest surviving hyperplast patient I've ever seen without operation. She was 12 years old when she died from pulmonary vascular disease. And this is an example from the UCSF archive, from our own archive, which shows this tiny little ascending aorta, the minuscule left ventricle, and the large right ventricle with an arterial duct which perfused the aorta retrograde. And this patient had a vein which, if you look at the cartoon, is coming more from the left side, running in a vertical direction like total anomalous pulmonary veins type 1. And here you can see this whole arcuate vein, which I put with the arrow so that you can recognize it. And there's the pattern. And you notice that this vessel doesn't come from a central conference, but it comes from the origin of the right pulmonary vessels. And here's such an example. And you can see that the flow is going away from the transducer. And then as it comes through the brachiocephalic, it comes towards the superior cava once again. So it looks like total veins type 1, but it's really a levoatrial cardinal vein, because you can see the little left ventricle in there. This is a very small left ventricle. So levoatrial cardinal vein. Here's some other examples. Here's the ascending aorta, and here we see the ascending aorta. Here we've got the pulmonary trunco. Here's the aorta with the left pulmonary artery. This is the right pulmonary artery here, but with a small ascending aorta, and off the back, you can see this, what we call collateral pulmonary systemic venous overflow vein running up here. And when we look at this in cross section over here, you can see all of the features. Here, I'm going to take the labels off, but look, there's the ascending aorta. And what you'll see here is when you take the labels off, I'm going to stop this. When you see this here, you can see here these two vessels. This one is the superior vena cava. Here's the right and the left pulmonary artery. There is the ascending aorta. There. And this is the collateral pulmonary venous overflow vessel. Okay, you can really see easily the ascending aorta, but of course there's no flow in it because the velocity is so low that it's missed because it's exactly at the wrong angle to look at the Doppler signal there. And here we'll just look at the specimen again from two different directions, a lateral direction here and a subcostal direction here. We flip the vein here so that you can see the vein running across here and showing the aorta over here. Here the pulmonary veins all coming into this vertical vein before it runs over to the superior cava. And so we look at this aspect over here, and you'll see the ascending vertical vein, just as you do in a type 1 veins. There's the left pulmonary veins draining vertically, and here below you can see the left atrium. The thing is continuous with the atrium, so that isn't like anomalous pulmonary veins because it has a connection. Here is the connection. This is left atrium, and this part over here on the right is the vertical vein. And that's what you're seeing here. As we look at this, I can just stop this for you and show you this. Okay, so there's the left atrium and there's the vein coming out of it. See? So it's not anomalous veins, but the flow is anomalous because there's a blockage between the atrium and the ventricle, and there is a restrictive or closed atrial septum. And that also is a risk factor for hyperplastic left heart syndrome. It's quite uncommon, but certainly a problem. Now we're going to finish by talking about small left ventricles not included in the hyperplastic left heart syndrome. These are small ventricles with aortic atresia and ventricular septal defects, excluded because of that one. Unbalanced right dominant AV septal defects, double outlet with mitral atresia, which we've discussed before, and extreme straddling, which we've also discussed before. So here's an example. This is a glass body. The heart was infused with glass and then subsequently digested, and that shows the apical four-chamber plane to do this. Here's the right ventricle, here's the left ventricle, here's a muscular ventricular septal defect, here's the left atrium. There is no connection between the left atrium and the left ventricle. So an absent connection, or mitral atresia, whatever you prefer to call it. Here you can see the pulmonary artery to the duct and descending aorta. Here is the preductal coarctation, so beautifully identified. The vessels, the head and neck. And in fact, because in this particular patient, there was right to left ventricular shunt, the aortic valve is patent, although small, and there is still prograde flow around the aorta, so the aorta is fairly large. Now, I'll only concentrate on this on the echocardiogram. I came across this patient who had a coarctation of the aorta, but had clearly an atresia between the left atrium and this underlying left ventricle. Here's the interventricular communication, and here's the incomplete left ventricle without a mitral valve in it. So mitral atresia or absent left AV connection. Here's another example from my own patient who had this condition, who was brought to us initially with the diagnosis of common arterial trunk or truncus arteriosus. And we're looking at the left atrium, I beg your pardon, at the right ventricle. We're looking at this tiny ascending aorta. Let's just take that off. There's the tiny ascending aorta, the large pulmonary trunk and the ductus, and the retrograde flow around the aortic arch. And this is the muscular ventricular septal defect cradled in the arms of the septum marginal trabeculation. And in case you missed this, this looks something like a common arterial trunk, because the ductus, the descending aorta, and the arch are then recognized, but not this ascending aorta. So there you see the tiny ascending aorta, the interventricular communication. It almost looks like the pulmonary trunk is overriding the aorta, and so these are often misdiagnosed as common arterial trunks. I'm going to zoom in on this for you for a second, and I'm going to stop this, and I'm going to show you how one can make a mistake by not seeing that ascending aorta. There's the ascending aorta, and you can even see some coronary artery coming off it there. And it's very small, as it usually is, and should not be missed. Now, these patients can undergo a connection of the ventricular septal defect to the pulmonary root, and then an arterial switch and a conduit placed from the right atrium to the pulmonary artery. So with a sort of, they call it a Norelli or a Yasui operation. And here is an unbalanced AV septal defect showing what could be considered a hyperplastic left ventricle, which it unquestionably is, but it's not hyperplastic left heart syndrome. And so here is an echocardiogram example, which we've shown you previously in the AV septal defect section. If you want to go back and look at the all of the meetings that we've had on this, you will find this there as well. By the way, I think Dr. Cohen will be talking about AV septal defects a little later on today. Evaluation of the post-Norwood needs a full echo. We've got to look at the atrial communication, the adequacy of the pulmonary blood flow, the adequacy of the arterial communication, ventricular function, tricuspid regurgitation, the presence of effusions. So let's look first at a patient who's just undergone a Norwood procedure, and the atrial septum has been almost fully excised here. This is the inferior buttress, which is not part of the atrial septum. It's part of the atrial wall, and that's why it's not excised. And then there's a little tricuspid regurgitation. And this diminutive left ventricle remains. And here, of course, we're looking at this widely opened atrial septum. This is the inferior buttress. This is the superior fold. The whole atrial septum has been excised. So you can't say the surgeon hasn't excised the whole atrial septum, because this is not atrial septum. It's part of the atrial wall. Now let's look at the homograft. Okay, we're going to do this in a subcostal sagittal cut. I'm going to take this away. And here you can see the surgery. The pulmonary artery and the aorta are anastomosed. Here's the anastomosis to the aortic F. Here's the native aorta. And a huge patch of homograft material is placed on the front to make the neo-aortic arch. So what we have to look at here is to make sure there's no pulmonary insufficiency. There's where the coronary blood flow goes now across the little hole into the heart there. Then we have to see the adequacy of this, and we have to pay particular attention to this area that is not actually shown over here, which is where the residual coarctations can occur. So a beautiful example of what is native tissue and what is homograft tissue in the Norwood procedure. And here is an echocardiogram, and you see there's the old aorta, here's the neo aorta, and there's this little communication over there. Okay. You don't see any flow coming across it because it's incident to the angle, so that if the cosine of 90 is 0, there's no recognition of flow. So you have to look at this with actually black and white imaging. Now, what about tricuspid regurg? I mentioned that tricuspid problems become a huge post-operative and long-term problem. So here's a patient who's undergone a Norwood procedure, and you can see that the valve is thickened and abnormal with multiple fusion jets of tricuspid regurgitation. And then the patient undergoes an annuloplasty, and here the surgeon has brought the pulmonary valve together, and he's certainly diminished, or she has diminished the amount of insufficiency, but you can see that there's now a gradient across the valve with a little jet. So we've traded some mitral insufficiency for some mitral stenosis in this particular patient. A very ominous and serious problem. Now we have to look at how the arteries are, and here we can see a patient with a modified BT shunt. Here's this little aorta, which is now anastomosed to the large pulmonary artery with homograph going over, and off the base of the innominate vessel comes this Aortic shunt, which is going into the right pulmonary artery. And here you can see that on the angiogram. And the echo provides you with a lot of use here, because you can see this with Doppler color flow. And I've superimposed a black and white image on a Doppler color flow image. And I'll stop this in a moment. Let me just make it larger for you so that you can see it. And now, if I stop this, you will notice that most of the flow is going to the left pulmonary artery across the duct. And that, in fact, when we look at the black and white image, that you can see that there's a narrowing of the right pulmonary artery in this particular patient. So very helpful to look at the, if you're still doing Blalock-Taussig type shunts, modified Blalock-Taussig shunts, to look at the vessels from the suprasternal notch position. And now we look at the Sano procedure, where Dr. Sano works at the University of California, San Francisco, my hospital. And here you can see the Sano conduit, which is a Cortex 5mm shunt. And it's going from the base of the right ventricle. Here, I'm just going to take the scale off because these are all subcostal pictures. And you can see here the homograph material across the new aorta. Yeah? Here's the old aorta on this side, the right atrium here. And now we're going to look in 3 pictures at the various features of this. So there's the old aorta. Here you can see the anastomosis line. Here's the new aorta here. And then there's the Sano conduit over here. So I'll just let you look at that for a minute without labels. Then here we've concentrated on this, on the Sano conduit. And we often use what we call the Kishimoto procedure, which is put in a little Contegra valve in the Sano conduit. And here you can see the Sano valve in the Contegra conduit over here. And largely at the other side of the heart here, we'll just magnify this up to look at the branch pulmonary arteries. Coarctations are the big problem. Remember, this is looking at the heart from the back. We're looking at it from the suprasternal sagittal cut. And here you can see, unfortunately, this patient has a residual coarctation over here. And that's why the patient died in heart failure, because a coarc on is an additional obstruction on top of a right ventricle, which is not geared to do all of this work, leads to heart failure and eventually death, as it did in this patient. And so here you can see the shelf very beautifully defined. This is looking at the back. So this is now the right pulmonary artery. The left pulmonary artery is here, and the heart is in the front here. The arch is not actually seen over here, but it's coming around here from the left side, which you can't really identify. So I wanted to bring this to your point, to your attention, a coarctation. And here is a post-operative coarctation in a transposition, in a Norwood procedure. And if you look in the abdomen and you look at the abdominal aortic signal is not like a normal abdominal aortic signal. It's flattened and attenuated with a hydraulic aspect to it over here. So there's a jet coming down the aorta. And here, when you look at this on the color flow, you can see the area where the coarctation has recurred. And here you can see with the Doppler variety that we've used here, that there is an area where there's almost complete obstruction. Now, other problems, infective endocarditis, you can see that there. We're nearly finished. You see the vegetations, and these are all thrombus that's infected is a vegetation. So here you can see that this valve, which is certainly abnormal, has got valve leaflets flowing across it. And if you try and stop this in diastole or in systole, look, there's the valve leaflet in fistule. The whole thing prolapses through the valve and appears on the right ventricular aspect. And of course, because the endocardium is abnormal, there's the presence, as you do in all cardiomyopathies, get thrombus, and here's a thrombus adherent to the wall of this non-functioning ventricle, which is always a risk. And here is the echocardiography, a pathology of the same. Now, just 2 or 3 pictures to show you the hybrid procedure, which you have to evaluate the interatrial stent, the pulmonary artery banding, the ductus stent, the adequate of aortic flow, and do a full echocardiographic evaluation for function, etc. Now, here's a patient who's had a stent placed across the atrial septum. A catheter got entrapped in this. The patient did very poorly and died, as often happens in this condition. And here is the stent across the atrial septum here, and you can see the flow is well established in this particular patient, who is not the same as this patient here. Here's the hepatic vein and inferior cava. Left and right atrium. Now we're going to look at the banded pulmonary arteries, and here you just see the bands are placed at the time of surgery, and then the bands are actually tightened by the team that are working in the operating room. And this is a post-operative example, and you can see the velocity of flow here shows that the peak velocity is 64 millimeters of mercury. The mean pressure is 31. That probably the pulmonary artery pressure was nice and low. There's unfortunately a small amount of pulmonary insufficiency. And here is the ductus stent, which has actually been tied in place, coming from the pulmonary artery here into the descending aorta here. Look how small is the aortic isthmus over here. And here you'll see the ductus stent. And you can see here that the ductus stent is doing well. And here is, you see this little hypoplastic isthmus over here, which maybe would need some attention. And here you can see that, in fact, that the descending aorta now is perfusing backwards into the pulmonary artery and back into the vessels, the head and neck. And so, ladies and gentlemen, we've concluded this long journey across the time, and we've actually done this in about 1 hour and 10 minutes. So I thank you very much for your attention, and I'm here to answer any questions if Grace wants me to do that. I'm going to stop sharing my screen so I can see you all.
Thank you, Norman. This is a session that we should keep forever and watch again, because it was impressive. Thank you very much. I really, really enjoyed it. Thank you.
I knew you would, because you're an intensivist.
So that's why I said that for
I
me
know.
it was something amazing, because I know nothing about echo, but all the inputs that you gave were very useful on the post-operative care of these patients.
Yeah,
Thank
I
you.
think that that's very important. I mean, this isn't just an amusing issue, but it's vital. And
Yep.
I think that you can see from the fetal example onwards that, I mean, if you look at the developments of congenital heart disease in the last 3 decades, hyperplasts have to be the most important issue. And it's common, unfortunately, common disease. The prognosis, as Gil Winofsky has said, when you look at teenagers that have had hyperplastic left heart, only 50% or less are alive. And we're going to need to move that a little better. Maybe we'll have artificial hearts and that sort of thing in the future. But right now, we have to optimize everything in terms of their care. And so this has to be done in this direction. So that's really what I have to add. And I think that you need to force your echocardiographer into rounds in the intensive care unit so that he can, or she, mainly she these days, can provide online direct feeding information so that it becomes important in the management of these patients.
Yeah, and all of these aspects of the echo on the post-op care of the hypoplast, hybrid or Norwood, is something that we discuss with the fellows and with the junior staff on rounds. We say, okay, we are going to ask for an echo on this patient. Which are the points that we need to be sure that they are all good? And we discuss this all the time. Unfortunately, we don't have the cardiologist with us on rounds, but it would be just perfect. But we have meetings every twice a week, so this is good. We are able to talk to them at least on these meetings twice a week.
Well, I
Okay, it was
see.
awesome. Okay,
Sorry, what
go
I
on.
see is I see that this POCUS, POCUS, point of care cardiac ultrasound. I think that if the cardiologists aren't caring enough, and of course we're very busy, but I mean I think that rounds are important, and I think that what I've discovered is there's a tremendous contribution to be made when you're on rounds and the team is standing there and you're doing the echo and they ask you for what they're interested in, then you actually meld this much better together. And I would say that, I know that there's, personnel resources are strained, but to my mind, that is really a very valuable addition.
No, it's super useful. It's really, really useful. I wish we could have programs to have that all the time, hopefully. We have two questions, and we are going to end up with these questions because of for the sake of time, but they are very good questions actually. So we have one question asking you to explain a little bit more about hypoplast in the setting of left isomerism.
The only thing we see is double outlet right ventricle with mitral atresia. We've seen that. I don't think that, and so of course this isn't hyperplastic left heart syndrome. It's a small left ventricle, and I tried to make this point. That's so isomerism almost invariably, when you think, of course, you see an absent left connection with a small left ventricle and a VSD. Think left isomerism. That's certainly the point that I would make. But I can't say that we can talk about it. Now, my friend Paolo Zielinski down in Porto Alegre is asking me about
So he's
when
saying,
there is mitral atresia in hyperplastic with absent left AV connection, since there is, in this case, the AV connection is univentricular instead of biventricular, are the atrial and ventricular septal malaligned? I think not, Paolo. Your questions are always very, very deep. And I don't know that I can give you a straight answer, but my feeling is I understand you're talking about like straddling valves and malalignment there. And of course, yes, in straddling valves, it is malaligned. But I think that this, when you see this again, of course, we're not talking about hyperplastic left heart syndrome anymore. We're just talking about a hyperplastic ventricle. So I don't know that that's really that important. And now let me just get on to I bring this to the surgeon's attention, and we obviously look and see how much. The question Miguel is asking is what you do if you find a cleft in the mitral valve. You know, I'm thinking of hyperplastic left hearts that I've seen. I've got, you know, like 2,000 of them over my career, and I can't recall many that actually have a cleft mitral valve that are true hyperplastic left heart syndrome. I think when you get into the double outlet right ventricle situation and you're talking about isomerism, then I think that the whole question of the AV canal is important. Miguel, you can remember the talk of Professor Anderson when he talked about the straddling of the valves. And what he said was that the straddling of the valve is not actually a ventricular problem. The problem is of the dorsal mesenchymal cap and how that goes. If it goes to the left, then there's a straddling of the mitral valve into the right ventricle. If it goes to the right, then the straddling of the right AV valve into the left ventricle. And that's what creates the septal malalignment. Okay, so I think the questions are interesting. They reflect some confusion which perhaps I have not been able to solve on one go around. But as this session will be available, and also a full text version is available through md1world.com, as you see at the beginning, I would suggest that you digest this again and again, as it's such a complicated issue, and see whether I've tried to answer those questions. I would also suggest that you go back and look at the previous session where we talked about double inlet ventricles, and look at that question and see whether you can answer some of the questions, because I think that they have been addressed in that earlier chapter of the book, chapter 12. Okay, so that's it, Grace. I can't hear you.
Sorry, I was muted. So thank you very much. Thank you, everybody, for attending today and for attending this awesome series. And Norman, thank you. It was great, and we are looking forward to continue. We have a lot of things to still talk about in the next sessions. I hope you have time to work more on your book, and I truly highly recommend to everybody to get these book chapters. I have them, and they are really useful.
Sure, I see two questions have just popped up. Sergei Falolenko said, how to differentiate aortic stenosis that can be dilated? Well, that's a whole different series, and you know, I can direct you to Dr. Turetsky's work. But the point about doing a dilatation, and Wayne has made this point very carefully, is once you've got hyperplastic left heart syndrome, you've got hyperplastic left heart syndrome. The dilatation is for critical aortic stenosis, okay? And I mean, this is an ongoing issue. Of course, I couldn't discuss this in any great detail, but of course, to decide on doing that, you should make sure that you have a long ventricle, that is not a short fat ventricle, etc., etc. And so I think that it's not really a question here, because once the ventricle is hypoplastic, there's no point in dilating it. And certainly the other point that Dr. Turetsky has made is, you know, you can't do this from 25 to 28 weeks. Usually this hypoplastic development starts between, let's say, 17, 18 weeks onward. And by 23, 24 weeks, most of it is already expressed. So you can't do it late, you have to do it early. And there, I don't understand the last question from Korovich. Where is the boundary between hyperplastic left heart and hyperplastic heart complex. Well, I don't know that I like that term, but hyperplastic left heart syndrome, as Professor Anderson has described it, is that it is a condition with concordant atrioventricular and ventricular arterial connections and without a ventricular septal defect. So once you're dealing with it, you can call a hyperplastic ventricle what you will. And they are hyperplastic in AV septal defects, as we've seen. They are hyperplastic in other conditions, like where there's a ventricular septal defect. They even can have a patent AV connection in when there's a big ventricular septal defect. So you can call what they are. They aren't hyperplastic left heart syndrome. They are just hyperplastic left ventricles. And I think we get bogged down in terminology sometimes. But I think we all understand what we're talking about.
True.
Okay, well, I think that we should say goodbye now, Grace.
Yes, thank you very much.
And we'll see you in September. I'm looking forward to the next series.
Me too. And hope to see you in the fetal webinar on the 29th.
Yes, I will be there, fetal, and I'm going to start getting ready to talk about hyperplastic right heart syndromes in the next section, and then follow that with the Epstein's malformation, or with isomerism, whichever I can get to first.
Okay. Thank you very much.
Thank you very much. Thanks, everybody. Bye-bye.